afternoon, friends and seniors. At the outset, I would like to express my sincere apologies for not making it in person because of an emergency. And I also thank the organizers for giving me this topic on bronchoscopic intervention of central airway obstruction. I'll be primarily dealing with a case-based approach of a central airway obstructions, and I'll just touch upon few cases of benign airway obstruction as well as most of it which will be dealt by the fellow speaker. So I will take you through a case, and during the process of this, we'll try to learn how we really manage a case of central airway obstruction, especially due to malignancy, with the help of a bronchoscopic intervention. So we have this patient who is a 32-year-old male, non-smoker, tobacco chewer. He presented to us with complaints of exertional breathlessness for 3 months, which progressed from grade 1 to grade 4. And the patient was also having a cough with a minimal mucoid sputum. There was no history of any hemoptysis, chest pain, wheeze. There was no history of any loss of weight or loss of appetite, and there was no history of any voice change or dysphagia or drooling of saliva. The patient did not have any prior comorbidities. There was no past history of coughs and no prior history of invasive mechanical ventilation or tracheostomy, and there was no significant response to the nebulization with bronchodilators. And on examination, there was no icterus, pallor, cyanosis or clubbing or pedal edema or generalized lymphadenopathy, and the patient was conscious and oriented, but was having a stridor which was grade 3, and the saturation was only 86% on room air, and patient was tachycardic, and patient was tachypneic with a respiratory rate of 35 per minute with the use of accessory muscles of respiration. And in the auscultation of the chest, you can hear a bilateral vesicular breath sounds with prolonged expiration. An ABG was performed, which was suggestive of a type 2 respiratory failure with a pH of 7.33, PCO2 of 50 millimeters of mercury, and PO2 of 55 millimeters of mercury. So before we move into this case, first let's try to understand what is really called as a central airway obstruction. The central airway obstruction can be either a malignant process, it can be a mechanical process, or it can be an obstructive process that impedes the airflow within the central airways. So we mean central airways when we are referring to trachea, the mainstem bronchi, and the right main bronchus intermedius. And the central airway obstruction is not always malignant. It can be because of malignancy, where it can be a primary tumor arising from the airways, or it can be a metastatic tumor, the most common being the breast, the colorectal, and the renal malignancies, or it can be an extrinsic compression or a direct invasion of an adjoining intrathoracic malignancy like a thyroid malignancy. But the point to be noted is most of the central airway obstruction in India are secondary to a non-malignant process. And the non-malignant causes that are most commonly associated with the central airway obstruction can be lymphadenopathies, especially tuberculosis, or it can be in inflammatory disorders like sarcoidosis or vaginous granulomatosis. Very rarely you can have an anatomical abnormality like a vascular abnormality like vascular rings, or most commonly in India, especially even after the post-COVID, we are seeing a lot of granulation tissue secondary to an endotracheal tube, a tracheostomy tube, the airway stents, the foreign bodies, surgical anastomosis, or vaginous granulomatosis. In addition to this, it can also be associated with other etiology like pseudotumors like hematomas, amyloidosis, or even a mucus plug. When we treat a central airway obstruction, we divide the central airway obstruction broadly into 3 main components. One, which is purely an endoluminal obstruction. The second one is an extraluminal compression. And the third one, where there is a mixed obstruction, where there is an element of endoluminal component along with an extrinsic component. Understanding this is very important because for a case where there is an extraluminal compression and a mixed obstruction, you may require the need of a stent to maintain the patency of an airway. But whenever the lesion is purely endoluminal obstruction, and once you debulk or mechanically debulk this lesion, then probably a stent is not required. In addition to this, the modalities that are required for attaining the luminal patency also differ depending upon the type of the central airway obstruction we see. And when do we really suspect a central airway obstruction? The unfortunate thing is most of the central airway obstructions are diagnosed very late because in the initial phase, they remain asymptomatic. And the most common symptom that is associated with the central airway obstruction is the cough. But along with that, the patient can also have dyspnea and can also have hemoptysis. And few patients can also have a post-obstructive infection. In addition to this, the patient can also have refractory dyspnea and wheezing. In a patient who is supposed to have an uncontrolled asthma or a COPD, you should always think of a central airway obstruction because there may be tumors which are slow growing, like in the form of a carcinoid tumor as well. So now moving on to the case. So this was the case we had, and the patient presented to us with a stridor, and the patient was in respiratory distress and in type 2 respiratory failure. So whenever you hear a case of a stridor, then you're almost certain that probably you're dealing with a case of central airway obstruction, and the presence of the stridor indicates a medical emergency, and these patients has to be treated on priority basis. So are all central airway obstructions significant? The answer is no. So only when a central airway obstruction is associated with a respiratory compromise or with an intractable symptoms, then we refer to as a patient has a significant airway obstruction. And this commonly occurs when more than 50% of the lumen of the diameter of the lumen of the central airways are obstructed. So whenever the luminal obstruction is less than 50%, we do not call them as significant airway obstructions. And whenever a patient does not have symptoms related to a central airway obstruction, then probably these are the patients who are to be observed conservatively and not to be aggressive on treatment with bronchoscopic interventions. But any patient of a central airway obstruction who presents with recurrent symptoms that are not amenable to treatment by medical management, or when the luminal obstruction is more than 50% of the airways, then they are referred to as a significant airway obstructions and has to be treated on priority basis. So having known the central airway obstructions, how are we really going to evaluate a patient with a central airway obstructions? So we got a lot of modalities available, like in the form of radiology, which can be in the form of a chest X-ray or a CT scan or a pulmonary function test or a bronchoscopy. So are we going to choose everything for every patient? The answer is definitely. Because when we move to the modalities like a chest X-ray and pulmonary function test, they have a very low sensitivity for picking up a central airway obstruction. And many times your X-ray may appear normal because the X-ray is not a very good modality to look into the airway lumen. And pulmonary function test, since most of the cases of a central airway obstruction generally present in a respiratory emergency, performing a pulmonary function test in such patients may be difficult. And generally these pulmonary function tests are not preferred in a patient in an acute setting. So any investigation that is to be ordered is dictated by the clinical situation and the stability of the patient. And CT chest, especially the thin section volumetric multi-dose CT, is the imaging modality of a choice whenever you are seeing a patient with a central airway obstruction. The advantage of the CT over other modalities is that it provides a 2D and a 3D rendering. It helps in the assessment of a lesion length. It helps in assessment of the degree of the airway narrowing. It helps in understanding the anatomical relations to the structures surrounding the airways. And you can also perform a virtual bronchoscopy, which allows the ability to bypass the obstruction to view the distal airways, even with high grade or a complete luminal obstruction, which precludes the passage of a bronchoscope. So because of all these things, we order a CT chest. But when ordering a CT chest, it is of utmost importance that you communicate what you are really looking for with your radiologist. Because a retrospective review of pre-treatment CT chest in 42 patients who underwent a therapeutic bronchoscopic intervention for central airway obstruction, the radiologist failed to identify central airway obstructions in 1/3 of the patients, and in the subgroup of the patients that did not have central airway obstruction, reported there was a significant delay in time to therapeutic intervention. This means until and unless you specifically ask your radiologist to look for a central airway obstructions, in 1/3 of the cases, your central airway obstruction may be missed. And it is the duty of a pulmonologist to really look into the airways to see a central airway obstruction is really present or not. So what all things that are to be seen in a CT scan when we are ordering a central airway obstruction? Look for the maximum degree of obstruction, look for the length of the obstruction and the luminal diameter of the airways, so that you can make an idea whether what is the diameter of the stent that has to be placed and whether really a stent has to be placed or not. And try to make a definition depending upon the type of the obstruction, whether it is a purely an intrinsic obstruction or an extrinsic obstruction or a mixed obstructions. And also locate the site of obstruction, the craniocaudal length, the relationship to the surrounding structures, and the distance from the trachea to the upper edge of the tumor, and the distance from the carina to the lower edge of the tumor, and the presence of a post-obstructive atelectasis. And look if the lung which is distal to the obstruction is viable or not. But this is a very controversial thing, because at the end, I would like to show you one case of a benign central airway obstruction where this theory was negated. But the most important thing that comes to the rescue whenever we are dealing with a case of a central airway obstruction is the flexible bronchoscope. The flexible bronchoscope have a lot of advantages over the CT scan in terms of a central airway obstruction. The advantages is that it is a gold standard. You can biopsy the lesions. And let's say that you've got a small cell cancer which is associated with the central airway obstruction, which is critical. Then probably once you diagnose it, you need not even stent it, because the mere administration of the chemotherapy can result in significant improvement in the central airway obstruction. But the problem with doing a flexible bronchoscope for a case with a central airway obstruction is that it may induce a bleeding and edema, which may probably convert a stable partial airway obstruction into an airway emergency. And particularly the use of the sedatives and neuromuscular agents has a potential to induce a complete airway obstruction, because it also causes the loss of the respiratory drive muscle tone. So whenever you do a bronchoscopy for a central airway obstruction, make sure that you have an adequate facilities for a rescue measures like a rigid bronchoscope and an OT setup, because what that was not a critical central airway obstruction can become a critical central airway obstruction because of the bleeding and the edema induced by the bronchoscopic intervention. So in the current case, we underwent with a CT chest and a fiber optic bronchoscopy. As you can see from the CT scan here, there is a near complete occlusion at the lower end of the trachea, which is causing almost 90% occlusion of the trachea. And this is the video, and this is how we perform a debulking. So when we did the procedure, what we were able to see was a stenosis which was present at the lower end of the trachea with the help of a flexible bronchoscope. But this flexible bronchoscopy was performed with a rigid bronchoscopic backup, because we know that we may convert this 90% into a 100% airway obstruction. So once it is done, which are the patients we are going to choose for debulking of the central airway obstruction? The predictors of the success for central airway obstruction is that whenever you got a pure endoluminal disease or purely an extrinsic compression, then probably those are the patients where your procedure will be successful. And this is as per the literature that is available. The predictors of the failure include a left mainstem obstruction, mucosal infiltration of the tumor, an ASA score of greater than 3, presence of renal failure, or a primary lung cancer, or a presence of a tracheoesophageal fistula. So before you do a central airway obstruction, make sure your procedure fits into this following algorithm. Are you doing it for a palliative or for a therapeutic procedure? And what is the type of the stenosis, whether it is purely an endoluminal or it is an extraluminal or it is a mixed? Treat the intraluminal component first and assess the degree of the airway stenosis. Treat the residual or the mural component next. And once you are done with this, then take up this patient for a management of a central airway obstruction. So here we are doing the bronchoscopy. As you can see from here, there is a stenosis at the lower end of the trachea. And we are evaluating with the help of a bronchoscope at this point. And once it is done, we are doing the serial balloon dilatation of the stenotic segment, as you can see from here. But even performing this is we are doing with the help of the CRE balloon dilation. And once we have done the serial balloon dilation with the CRE, even after that, you can see that the airway is not completely opened up, and still it is edematous. So now we are removing the CRE balloon. So then what we are doing is, since there is a component of both extraluminal and an intraluminal component, what we are doing is a mechanical debulking of the tumor. So here we are using the rigid bronchoscope to core out the remnant tissues that are present within the lumen. As you can see from here, we are using the rigid bronchoscopic mechanical debulking. This has to be done very carefully, because even a slight deviation from the plane of the debulking can result in an airway perforation. And once it is done, then we are using a cryo to remove the core tissue that is present inside the airway. So here we are using a cryo to remove the tissues that are present inside the airway, as you can see from here. So once it is done, now we know that we have attained adequate intraluminal recanalized tracheal lumen. But the problem is the airway is looking very edematous. So we need to probably stent this airway, because even post-procedure, if the edema increases, again, the patient may go in for a respiratory compromise. So right now we are placing a silicone Y stent, because this tumor was occurring at the lower 1/3 of the trachea. And with the help of the forceps, we are manipulating the silicone stent so that the stent is in position. And right now we have attained a 100% luminal patency, and the patient is then extubated on table. And in this case, the post-procedure X-ray looked like that, and the patient turned out to be a case of an adenoid cystic carcinoma. And for this, the patient was then subsequently sent for the surgical consultation for removal. But the patient, as per the multidisciplinary discussion, the patient was then put on radiotherapy because the surgeon felt that the tumor was surgically not operable. We have another patient, and in this case, what you can see from here, we did a virtual bronchoscopy of the patient, and what we can see was there was a flap-like tumor which was obstructing the trachea. So this was a case of a granulation tissue following post-intubation. My friend Dr. Nagarajun sir would be dealing with most of the benign airway. I just want you to show how we really do, because the topic was more of a bronchoscopic interventions for central airway obstruction. So here we saw a tracheal granulation tissue which was causing the obstruction of the tracheal lumen. And as you can see from here, there is a presence of a necrotic tracheal slough, and there is a flap valve-like granulation tissue which was present at the subglottic region, which is causing dynamic obstruction whenever a patient is in a sitting position. So what we are doing is we are using a cryo to remove this granulation tissue, as you can see from here. And once it is removed, again, we are using the mechanical debulking of the residual granulation tissue with the help of the rigid bronchoscope. And once it is done, we are applying a mitomycin to prevent the recurrence of the granulation tissue. And once it is done, you can see from here, we are doing a CRE balloon dilatation. And now the tracheal lumen is completely patent, and the patient is then extubated on table. And this is another case of a malignant central airway obstruction. So here the patient was a case of a CA thyroid who had undergone a partial laryngectomy, and along with that radiotherapy. So such cases, there is a difficulty of a rigid bronchoscopic intubation because of a limited flexibility of the neck. So once it is done, we are intubating this patient with the help of a rigid bronchoscope. And as you can see from here, there is a malignant tumor which causes more than 90% of the occlusion of the airway. So here we are using a Fogarty balloon and a suction catheter which are placed distally to prevent the spillage of the lower part of the lung by the blood when we are doing this debulking. So here we are looping the malignant tumor with the help of an electrocautery snare. And once it is done, we are partially cutting the tumor with a snare, and then we are removing it with the help of a cryoprobe. And since the tumor has got a wide base, it is not amenable to complete resection by electrocautery snare. So what we are doing now is we are doing a mechanical debulking with the help of a rigid bronchoscope. And in that process, you can see that we are also coring out a portion of the cartilage which has been invaded by the tumor. Now you can see that we will be breaking the cartilage of the airway also. These are not to be advised when you are starting your IP career, but in certain cases, you may have to do it to attain a luminal patency. So here we are breaking the cartilage of the trachea with the help of the rigid bronchoscope. And once it is done, now we have placed a self-expanding metallic stent, and the patient has attained 100% luminal patency, and the patient is then extubated on table. And this is yet another case where it presented with a young female with a polypoid, bilobed polypoid mass in the mid region of the trachea. So since it is a polypoid mass, we underwent electrocautery snaring. As you can see from here, we are placing an electrocautery snare, and we are snaring out the tumor. So once the tumor is partially cut, now we will use a cryoprobe to extract this tumor from the airway, as you can see from here. And again, whatever the leftover second lobe of the polypoid mass is now snared again. And once it is done, the entire polypoid tissue is removed. And then we are using an APC to attain a hemostasis during the procedure. This is a non-contact mode of hemostasis. Then we are keeping an adrenaline soaked gauze also to attain hemostasis. And once it is done, the bleeding didn't stop, so we have to use a Fogarty balloon, and whatever the residual tumor that was left behind, we are using the rigid bronchoscope to cause the mechanical debulking. And once it is done, we are using a cryoprobe to cause the cryoablation of these tumors. And again, we are using a APC to attain hemostasis. And as you can see from here, after that, the tumor is totally removed and we have attained a 100% luminal patency, and then the patient is extubated on table. This is one last case I would like to show, again, a case of a benign central airway obstruction. So this patient had a history of TB medicines 2 years back, and followed that the patient had a complete collapse of the left lung. And the patient has become oxygen dependent, and he was crippled and he was on oxygen support for 6 months. And after 2 years of collapse of the lung, he reported to us. Generally, the dictum says that do not intervene in such patients. But when we did a bronchoscope, what we were able to see was the left main bronchus was completely stenosed. So we did a cryo recanalization of the left lung, and the left main bronchus opened up. And as you can see from here, the left picture shows a completely expanded left lower lobe immediately following the procedure. And the right one shows an X-ray which was done almost 4 months better. Organizers, once again, for giving me this opportunity, and my sincere apologies once again for not making it in person. Thank you.